Bhubaneswar, Jabalpur, they are doing mainly work on sickle cell. At Dibrugarh, it's mainly E-thalassemia. And Port Blair in the Andaman Islands have done some small surveys in some of the primitive tribes over there. So in the 70s and early 80s, a lot of tribal and non-tribal groups in different states were screened by various ICMR institutes, and this showed a variable frequency of the sickle gene from 1 to 22% in many tribal groups. What some of these studies also showed that beta thalassemia was also common, 6 to 8% in some tribes in Odisha. And later work that we have done and others have also done have shown that in fact, beta thalassemia is not common in the tribes. It was just not looked for earlier. So we have to look at both thalassemias and sickle cell disorders. In the mid-80s, there was the first task force on thalassemia by ICMR, where high school children were screened, taking 3 centers, one in Mumbai, one in Delhi, and one in Calcutta, to represent 3 zones of the country. And over 11,000 children were screened by the then available technologies, which was CBC and electrophoresis. And that clearly showed that there was a wide variation between the 3 regions in the prevalence of beta thalassemia. Family studies, counseling, everything was done at that time. And at the same time, there was another task force of ICMR, which involved establishment of prenatal diagnosis. At that time, it was second trimester prenatal diagnosis, and the first center for globin synthesis and prenatal diagnosis was established in Mumbai at the National Institute of Immunohematology. And although molecular techniques were not used then, it was still shown that beta plus thalassemia was more common than beta 0, which we now know that the IVS15 mutation is the most common mutation in Indians. Normal A2 beta thalassemia today we know is a big problem, particularly in counseling. And right then also we had picked up cases based on just doing the globin synthesis. Then came the Indo-French workshop in '86 with ICMR supported with Dr. Dominique Claby and Dr. Jacques Elion and others from France. And this really set the ball rolling for us to establish molecular technology. At that time, the French group brought in all the infrastructure that was needed. And later on, we did the same thing, as I'll show you a little later, in trying to set up other centers in different parts of India. Following that Indo-French workshop, there were collaborations with INSERM and ICMR, as well as CEFIPRA and ICMR. And one major thing that was seen from that work was that tribal populations in Gujarat versus non-tribal populations in Maharashtra had a very different clinical presentation, although they both had the Arab Indian haplotype. The prevalence of alpha thalassemia was very different, being very high in Gujarat as compared to Maharashtra. Then in 1997, there was a national hemoglobinopathy control program which was recommended after an ICMR and a joint ICMR-DBT brainstorming session which took place again in Mumbai at our institute. And it was recommended that there should be 5 apex centers in different regions, and under them there would be several centers who would be working. Now, although the national program has not yet taken off, probably now it's maybe about to take off, what did happen was the concept of networking started so that data could be accumulated in a uniform way and analyzed in a uniform way, and also with the involvement of primary healthcare centers and collaboration with different NGOs. So Dr. Mohanty was very much involved, and she was one of the main persons who tried to get the network together, and she had arranged the first visit to Dhule, a field visit, involving all the centers in India at that time, the major centers who were working on sickle cell disease. You can see here Dr. Kate is there, Dr. Jyotish Patel, who are both here today. And following this, there was the first network project between ICMR with an NGO, Jigyansu Tribal Research Center, and Dr. Kate at the BJ Medical College. And here in Dhule and Gadchiroli, the first awareness programs were done by the NGO, and screening and counseling was done by the two centers. The clinical profile of the patients were also recorded, and you can see here that painful events, hospitalizations, infections, and splenomegaly were the ones which were recorded. After that followed two major national programs of ICMR, and one was called the Jai Vigyan Science and Technology Mission Project on community control of thalassemia, and the second was on sickle cell, that is on intervention program for nutritional anemia and sickle cell disease in primitive tribes. Now, both these programs, they aim to develop different new centers, particularly in medical colleges. 5 centers were to be developed under the thalassemia program and 5 centers under the sickle cell program. And so the thalassemia program involved awareness, screening, providing training, counseling to 6 different centers in 6 regions of the country. And this went on very successfully. Mainly it was medical colleges where the programs were conducted. And what was seen before, at the beginning of the program, was that there was very little awareness. 2 groups were included, college students and pregnant women. And both of them, in the 6 different states, there was very limited awareness. So a lot of awareness programs were done by each center by using posters, giving talks, and also by way of the press. And the distribution of hemoglobinopathies in these states, 6 states, was studied. And beta thalassemia varied from about 2 to 4%. Hemoglobin E was mainly in Dibrugarh and Calcutta, and sickle hemoglobin in Gujarat. Another thing that was found was that in the antenatal cases, there were a large majority which only came for the first time in the 3rd trimester or late in the 2nd trimester. So that was another problem. And a lot of counseling was done for that as well. So different technologies were used. Each center screened about 10,000 individuals. And what was seen was that if one used the osmotic fragility and red cell indices together in the first step, you missed the least number of heterozygotes, 1.9%. Couples were identified at different centers and at that time sent to Mumbai for prenatal diagnosis. With all this large data that we had available on the prevalence, we were able to do some kind of micro-mapping to look at the district-wise distribution of beta thalassemia, and this just shows in Maharashtra, where we saw that there was an uneven distribution in different districts, and based on that we could calculate the true burden, with 588 homozygotes estimated to be born only in one state. So this kind of information would help the public health authorities to develop programs in districts where they are most needed. In the second program on intervention and nutritional anemia and hemoglobinopathies in primitive tribes, here again, there were 5 centers which were involved who did the screening, clinical evaluation, intervention, and follow-up. And the center in Mumbai, NIH, was involved in training, doing the HPLC analysis, although all the centers were again given equipment and adequate training, and ICMR headquarters was involved in doing all the data entry. So in this primitive tribe study, it was found that anemia, iron deficiency were very common. Sickle cell trait was very variable, and so also beta thalassemia trait from 0.9 to 4.8%. G6PD deficiency was also very common. And then intervention was given to the iron deficient cases as well as the sickle cell disorders. We initiated a little bit of neonatal screening at that time at one center in Nagpur and one in Gujarat, which then went on to become bigger programs. And in this, one other thing that was found was that there was iron deficiency along with sickle cell trait and sickle cell disease in many of these cases. quality control programs were regularly done. And once this was over, the second phase of the Jai Vigyan programs took off, which aimed at establishing molecular and prenatal diagnosis at few of the centers from both these programs. And this was to be done initially in 5 states. Again, it involved a lot of training, a lot of hand-holding, which had to be done over several years. And the program was, well, I won't say it was 100% successful, because we were initially able to establish prenatal diagnosis in all the centers and molecular analysis. But unfortunately, when the ICMR study got over, there was a commitment earlier from the state governments that they would take on and continue this work, but we ultimately ended up with only 2 full-fledged centers, one in Calcutta and one in Ludhiana. And at the rest of the places, somehow the program could not go on. By that time, we knew what was the distribution of mutations, and we knew the common mutations, and based on that, our institute, based on the reverse dot blot technology, had prepared a kit and patented it to detect the common beta thalassemia mutations along with hemoglobin S and hemoglobin E. This kit was released to the nation by the health minister and the DG at that time. And it has been tested at few centers. The last lot of kits are just now being prepared. And once these are tested, there's a company from Bhubaneswar who is, in fact, has an MOU with ICMR to prepare these kits. So once this last lot is tested, hopefully they will become commercially available. And apart from that, there are a lot of translational research programs of ICMR, where workshops have been done by the National Institute of Immunohematology for medical colleges, because one of the mandates was strengthening genetic services in medical colleges. So we had done 8 workshops in different states covering 45 medical colleges, where doctors, technologists, all of them were trained. And apart from that, we have also been involved, ICMR has been involved in providing training to the NHM and to the Ministry of Tribal Affairs, where in the last couple of years, a lot of workshops have been done for them to establish screening technologies. ICMR also started a tribal health research forum a few years back, and under that, newborn screening was started at 2 centers in Gujarat and Jabalpur. Facilities for prenatal diagnosis again are being established at 2 more centers. And a Center for Newborn Screening with the help of ICMR has been established in the northeastern region in Tripura. Then there was a genomics program of ICMR where the benefits of low-dose hydroxyurea was studied along with Dr. Dipti Jain in Nagpur. And along with KEM Hospital in Mumbai, it was also studied in thalassemia patients. And later on, the hydroxyurea was also shown to be important in iron chelation. It was shown to have a synergistic effect with other chelators in an animal model. So this already has been talked of before, and Dr. Swaminathan also just said that the 4-acre land has been acquired for a national sickle cell and hemoglobinopathy training and research center in the center of Maharashtra and Chandrapur, and some work has already been initiated here. So to summarize the contributions, a lot of epidemiological work was done in the early days. The clinical presentation, molecular pathology has been studied, prevention programs developed, a kit was developed. Then several multi-center studies were undertaken to establish new centers. Medical colleges have been strengthened, human resource development has taken place. And the last and the most important is that ICMR, the individual ICMR centers have been involved in a lot of research projects. There's no time to go through all these, but some of them have already been presented or put up as posters or oral presentations. Thank you very much. I'd like to acknowledge all the people, many people who have been involved with our institute as well as the other ICMR institutes in trying to establish all these facilities. Thank you.